Hello everyone, I'm Richard Conway from Dublin, Ireland, and this is QD Clinic from RheumNow. And today's case is of progressive rheumatoid arthritis interstitial lung disease. So this is the case of a 58-year-old man. He's an ex-smoker. He's been attending my clinic for the last 10 years or so. He's seropositive, strongly so, for rheumatoid factor and CCP antibodies. And he has a known diagnosis of rheumatoid arthritis interstitial lung disease. He's on methotrexate and adalimumab for the treatment of his rheumatoid. His arthritis itself has been under relatively good control, but seems to become a little more active in recent times. He's quite a stoic man, so he's not really complaining of very much. But when we do his disease activity measurements, his CDAI is 15, his DAS28 CRP is 3.3. So we're looking at somebody with a moderate level of disease activity. Seems acceptable to him, but possibly shouldn't be for us, even in the absence of the interstitial lung disease. This man has some pulmonary symptoms. He's had a dry cough. He doesn't have any dyspnea, but this cough is bothering him and interfering with his social activities more than anything, especially in the modern post-COVID era. People can get a bit self-conscious about their coughs. We listen to his lungs. He's crackles, kind of the bases up to the mid zones on both sides. So this is something we need to investigate further. We do a chest X-ray. We see some fibrotic changes on that. We get him some pulmonary function tests. And pulmonary function tests show that he has an FVC of 57% and a DLCO of 45%. So straight off the bat, these are not good numbers. These are relatively severely impaired pulmonary function tests for somebody. You should never look at pulmonary function tests in isolation. So we know this man has interstitial lung disease. So he's been attending our clinic. We've been keeping an eye on his pulmonary function tests. We look back on those. His DLCO, now it's 45%. A year ago, it was 55. A year before that, it was 65. So we've had quite a steady downward trajectory in this. And his FVC, it's 57% now. A year ago, it was 65%. Before that, it was 70%. So this man does seem to have progressive interstitial lung disease in the setting of rheumatoid arthritis. And the question is, what should we do about this? So he's on methotrexate and a TNF inhibitor. These had previously kept his disease under control. They're not currently doing it. His rheumatoid is active and his interstitial lung disease is now progressing, and it's progressing down to relatively low levels at which we might start to be running into trouble in terms of the need for oxygen and possibly even considering things like lung transplants. So if we can do anything to arrest this disease process, we should do it now. And what should we do is the question. And that is something that has been very controversial in recent times. There are options here. And maybe we should do one thing, maybe we should do more than one thing. Different people might do different things in this situation. What I'm thinking and what I have done here is that this man is on methotrexate. Should we continue that? And that's an easy answer for me. We should continue it. There's no reason to stop methotrexate here. We're not dealing with a pneumonitis worsening his lung function. We're dealing with progression of his long-term rheumatoid pulmonary fibrosis interstitial lung disease process. And there's no evidence that methotrexate worsens that. There is some evidence that it might benefit it. So the only likely thing you are to achieve by stopping methotrexate is to make this man worse. Don't think there's any possibility that that will make him better. We should do a CT scan to see exactly what's going on here, because we know the lung disease is worsening, but what does it look like? So we did a CT scan in this man and we saw that he has basal subpleural predominant fibrotic changes with honeycomb and traction bronchiectasis. So he also had quite a bit of ground glass change throughout his lungs. This is suggesting that there is some reversibility to this process. So our next consideration was with regard to his biologic agent. So the TNF inhibitor does not seem to be controlling either aspect of his disease process. So we would consider a change in that, and we did. In this setting, I changed this TNF inhibitor to rituximab. Is one of my favored agents in this setting. Again, the evidence here is not necessarily fantastic, but I think it does have perhaps the best evidence in terms of biologic agents for treating this. Other reasonable options would be, well, pretty much any non-TNF inhibitor biologic, so abatacept has some decent evidence, tocilizumab has some evidence, JAK inhibitors, some emerging evidence as well. I think really the key is to change the treatment that's not working. In this case, we chose rituximab. We did a second thing here. We added in nintedanib, and I know that might be controversial to some, but nintedanib actually probably has our best level of evidence that it is beneficial in rheumatoid arthritis, interstitial lung disease, randomized control trial evidence. It has what some may argue is a mild to moderate benefit, but it is definitely a real benefit in slowing down the progression of the fibrotic process. Nintedanib and agents like it, they do have quite a high adverse event burden, so it's always something we're initiating as a trial of an agent, not necessarily something that they're definitely going to say on, but this man tolerated it well, and so why not have it there for the benefits it can do in slowing down the progression of his ILD. So that's what I did in this situation, rituximab and nintedanib. Other people here might have either kept the TNF inhibitor there and added in mycophenolate mofetil, or switched the TNF inhibitor to mycophenolate mofetil. It's not something I'm terribly comfortable doing when his arthritis disease process is also active, but some will advocate for doing that for his lung disease. But I didn't. So the rituximab and nintedanib, we started these, and we stopped the TNF inhibitor, continued the methotrexate. We saw him back again 6 months later, and he was feeling a bit better. The cough was still there, but it had reduced. We did his pulmonary function tests again. His DLCO was risen back up to 55%. His FVC had improved back to 63%. So things seemed to, they certainly stopped their downward progression. They seemed to be improving. So it seemed like we'd gotten this man back on track. And his arthritic disease was now completely quiescent. So I think the learning point here is that if things aren't working out and they're progressing on your current treatment, you should change that to something else. There is limited evidence about what we should change it to, but the basic principle for me always is your initial priority is to achieve disease control of his rheumatoid arthritis process with whatever agents you need to do that. So that's been today's QD clinic, and tune into RheumNow for more QD clinics.